Happy to introduce Dr. Robert Seiss from Frontier Psychiatry, and he's going to share with us some really exciting things that their group is doing in Montana now. Dr. Seiss.
Thanks so much, Tamara. Please let me know if there's any issue with audio at any time during the presentation. Don't hesitate to interrupt. Brief disclosure, I am one of the co-founders and owners of the telehealth company Frontier Psychiatry. We'll talk about our goal and mission, how we serve patients with a specific focus on emergency and crisis care, as well as MAT. Talk about our team, some of the technology we've developed and what we aim to develop over the next few months, recognize our partnerships, and time permitting, talk about the urgency of increasing access to opioid use disorder treatment and COVID's role in this. Doctors Eric Arzubi, Reza Hosseini Gomi, and myself founded Frontier Psychiatry in 2019. Now, just because you found a business doesn't mean you're successful in the launch. We discovered right away this required an incredible amount of planning, logistics, and partnerships throughout the communities in Montana that we've ultimately succeeded in serving. We essentially went live in offering patient care in January of this year on the broad scale across the state. We like to say what makes all of us common insofar as our perspective on care delivery and how we approach patients. We very much want to meet patients where they're at, not only physically, but also in their willingness to change, get treatment, and advance in recovery, be it a substance use disorder or a co-occurring disorder like depression, PTSD, bipolar disorder, schizophrenia. And our central goal is to make psychiatric care accessible to every Montanan in need by 2025. We think we're well on our way to doing this. In addition to general outpatient psychiatry, we offer subspecialty care, including addiction and co-occurring disorder care. I myself am a boarded addiction psychiatrist. Child and adolescent, we have a total of 5 child and adolescent psychiatrists, consult liaison psychiatry, emergency psychiatry, geriatric, as well as neuropsychiatry. We have board certified psychiatrists in both. And finally, we have a perinatal psychiatrist. There's no formal board for this, but there is some additional training she's taken on to become expert. We emphasize using a consultative model. The last thing we want to do, as we see it going against our goal of making sure care is available to everyone by 2025, the last thing we want to do is somehow take away patients who have access to care in their communities. Rather, we want to serve as a bridge from the acute and urgent, following people out of hospitalization or emergency department visits, making sure they have, if not next day care, care the same week, and continue to follow them until they can establish a community provider. Our patients come from across the state, and our outpatient practice has grown significantly. We anticipate by the end of the year, we'll be up to 2,000 encounters monthly. But that in many ways is a prelude to talk about what I think is most pertinent to this conference, specifically our emergency psychiatry service offering and how we offer medication-assisted treatment as an embedded service. We partnered with Montana Hospital Association in January to launch Frontier on Call. This is a 24/7 psychiatric consultation service focused on serving emergency departments, though we also care for patients who are admitted to the hospitals where these EDs are located. The service debuted at St. Peter's in March of 2021. What I think is very unique about this partner in particular, they have their own psychiatric practice. That said, their psychiatrists were not going to the emergency department. Unfortunately, that has been a recurring theme, not only here in Montana, across the country, and we aim to change the extent to which psychiatry makes itself accessible to patients when and where they need it. Just as cardiology would come to the emergency department, GI, almost any other subspecialty, so too must psychiatry. Currently, we're serving 8 emergency departments: St. Peter's in Helena, Barrett and Dillon, Francis Mahon up in Glasgow, St. Luke in Ronnan. They're rapidly becoming our biggest source of consults. Glendive Medical Center, we also cover the behavioral health unit there on some weekends. Livingston just recently went live. We're seeing roughly 2 consults a day there. Roosevelt Medical Center, as well as Bighorn Hospital. We have 5 other launches planned in the next 2 months. We started off quite small insofar as the number of consults. This is growing, and most recently, we're seeing a doubling every month. We are very excited that we're able to, through a partnership with Eastern Montana Community Mental Health Center and SCL Health's Holy Rosary Healthcare in Miles City, we're launching empath units, 3 empath units in Eastern Montana. For those who aren't familiar with the empath unit concept, it really turns the traditional psychiatric emergency department design on its head. For those of us who trained at large medical centers, myself at UW Harborview, a psychiatric ED is a subunit that's often locked within the emergency department with almost jail cell-like rooms where patients are boarded until a psychiatrist can make it over to assess. It's a very non-patient centric, some would argue inhumane way of treating patients, whereas empath units, patients get assessed on arrival. They're treated with dignity. They're welcome to an open space with recliners, and COVID allowing, have access to almost a food bar of sorts with coffee and sustenance that they can take oftentimes while they spend the night. We'll be providing psychiatric coverage, and MAT for opioid use disorder will be a core service offering in each of these crisis centers. We're able to do this because of our team. We've been incredibly fortunate insofar as who we've met over the last year and also what COVID's done. COVID in many ways has taken telepsychiatry from the 1.0 to the 2.0 phase, in that now delivering commodified service is no longer an option. People know they can get better, they demand better, and we aim to give them better. Instead of going incredibly broad, we're going as deep as we can into serving Montana. To do that, we are looking beyond Montana for our physicians and nurse practitioners. That said, the majority of our workforce is Montana-based. In addition to the child adolescent psychiatrists, Eric Arzubi, Ankur Patel, Janelle Arias, the Yale Child Adolescent Psychiatry Fellows, Dr. Ayubelo, Paez, and Dr. Ahmed. It looks like I'm a host, I can admit people. We do have several general adult psychiatrists, nurse practitioners who come together to serve patients in a variety of clinical settings. Many of these people, the majority, also serve the EDs. Just recently, we launched on a joint venture with Memora Health. It is a telehealth company based out of San Francisco with a market cap of around 100 million. They have taken interest in us, not because we're big, not because we compete against University of California, San Francisco, or Yale, but because we're doing something unique. In particular, they have been instrumental in helping us launch a pathways program where we're creating patient-centric technology that will allow patients after discharge from the ED using their mobile devices, and this is our specific app available on the App Store, to chat with us, let us know how it's going. If we do start buprenorphine, we can check in. Perhaps initially in an automated fashion, they just get a reminder, how's it going? Did you pick up your prescription at the pharmacy? How are your cravings today? And as much as possible, in a collaborative fashion, assess for ongoing use and what we can do to engage the patient and ideally reduce use, if not help them get to abstinence. We are also very grateful for our community partnerships. The Montana Community Foundation, in partnership with the Arthur M. Blank Family Foundation, has created a fund. While it's not finalized, my understanding is the initial offering is $150,000 that will allow us to continue to serve all patients presenting to emergency departments, regardless of their ability to pay. This is something we're already doing. That said, we anticipate as we scale up, this is something that's going to become ever more common. Most of our revenue is coming from billing Medicaid and other insurers. So if we're caring for folks who are uninsured, this is going to be instrumental in helping us scale. It will also help us expand our current pro bono outpatient service offerings. Tamara, if you could stop me if we get questions. I'm not paying attention to the chat. Thanks so much. This is our Frontier Recovery team. We're 3 psychiatrists, and we're about to be 3 in some way addiction boarded psychiatrists. Both Eric and Reza are sitting for the addiction medicine boards in October. Eric was actually set to sit for them last year, but got COVID. And we have 3 nurse practitioners, all of whom practice medication-assisted treatment to scale. And so, of course, this centers on buprenorphine, in some cases, IM naltrexone for opioid use disorder, but it also deals with MAT for all other sorts of substance use disorders. And it goes without saying, as a psychiatric practice, we emphasize concomitant treatment of everything co-occurring, be it PTSD, depression, bipolar. Our treatment focuses on, first and foremost, assessing how we can meet patients where they're at. And here, motivational interviewing, as Dr. Poland so eloquently described, it is front and center in having any sort of meaningful patient-centric conversation. MAT for opioid use disorder is part of the medication management we do. We also do MAT for alcohol use disorder. If everyone could make sure they're muted, I'm getting a little bit of reverb. 12-step facilitation, linkage to chemical dependency counseling, and as I mentioned, diagnosis and treatment of everything co-occurring. We emphasize going a step beyond just the MAT, as the data indicates, for long-term treatment, and to emphasize this is long-term. We've seen that for emergent care, MAT by far and away has the greatest treatment value. That said, when you're looking longer term, and specifically for retention and treatment and long-term outcomes, and here we're focusing on return to function, a psychosocial intervention, be it CBT, contingency management, community reinforcement, or combined behavioral intervention coupled with CD counseling, and ideally attendance at a mutual help group. For better or worse, here in Montana, that essentially is synonymous with 12-step, because there's so few kind of alternative mutual help groups. Those that are alternative are probably not alternative in the ways that most people who, for whatever reason, find 12-step doesn't work for them, they wouldn't go to these alternatives because they tend to be even more religiously focused. Why is this so pertinent now? So just as COVID-19 made telepsych in many ways more commonplace, more in demand, at the same time informed the market, making it more likely to identify quality, COVID-19 had an incredibly detrimental effect on mental health overall, but in specific, when it comes to opioid use disorder and mortality that results. I want to just briefly talk about the trends in opioid overdoses prior to COVID to give context. From 2002 to 2017, we saw an explosion in the number of deaths involving fentanyl and other synthetic opioids, 22-fold increase. The same period saw a 7-fold increase in the number of deaths involving heroin. Over 72,000 Americans died from opioid overdoses in 2017. So a 2-fold increase in a decade, with, in that year, fentanyl and its analogs associated with 30,000 overdose deaths, heroin being involved in 16,000, and prescription painkillers were involved in 15,000. I think the narrative that has been most succinct and best helped me summarize what's happened in this interval over the last 20 years, it really is waves that have coincided to create this horrific epidemic resulting in a staggering death toll. Initially, in the early 2000s, we're all very familiar with the boom in commonly prescribed opioids. Next on the scene came heroin. In many ways, people were trading it out for the prescribed opioids. And most recently, and very concerning, is the explosion in fentanyl and its analogs. Opioid use in COVID-19 went up by 30% in 1 year, highest ever recorded number of opioid-related deaths, likely due to the same factors we saw impacting mental health overall: increased unemployment, social isolation, increased overall stress, and at the same time, a decrease in access to care. Here's a heat map of the US. You see that Not all states were equally impacted. That said, virtually every state, and I'd really want to contend on the data keeping and analysis of South Dakota and Alaska, but in general, you can say virtually uniformly across the country, everywhere saw an increase in opioid-related deaths. Even here in Montana, when we were starting to do a little bit better, right around 2018, we've seen an uptick in keeping with the rest of the country throughout COVID. Do want to acknowledge kratom. While it is not nearly as fatal as opioids, as it does behave differently, and specifically, we're talking about kratom abused at doses in excess of 5 grams a day. It does act as a partial mu opioid receptor agonist. And as such, when combined with other respiratory depressants, in extreme cases, it can cause death from apnea. We are seeing a boom in kratom overdoses. And part of this has to do with access and supply. Remarkably, kratom is available over the counter recreationally in the vast majority of markets across the United States. And this is despite the fact that as a mu opioid receptor agonist, some would argue at the higher doses, it behaves in many ways similar to buprenorphine. So here we have a substance that is more dangerous than buprenorphine insofar as how it's used, but is way less controlled, not even scheduled. It's pretty wild, but that's the situation we're encountering. Fortunately, the same type of MAT we use for opioid use disorder oftentimes also helps significantly with kratom. Most immediately, buprenorphine, in some cases, IM naltrexone for alcohol use disorder. MAT really centers on naltrexone. In particular, IM naltrexone is incredibly effective, in particular in the harm reduction approach. Gabapentin can be used to augment the effect of naltrexone, at least in the short to medium term. Disulfiram, if it's observed dosing, and acamprosate, it doesn't work in the US in the most recent study, but some people still use it. For cannabis use disorder, for those folks who are motivated, we can leverage gabapentin. For stimulants, we're stuck using really evidence that comes from the frontiers of addiction medicine. There was a Trivedi article published in January of this year using IM naltrexone dosed 380 milligrams every 3 weeks with max dosing of sustained release bupropion. They did see about 11% reduction in use beyond the placebo group. And there is some evidence for using disulfiram for cocaine use. It's worth emphasizing that across the board for the majority of these substance use disorders, the psychosocial interventions play a huge role, and some would argue they're the crux of treatment. That said, and can't emphasize this enough, I think my colleagues, Ariana, Andy, and Kara have really highlighted this. I want to do it once again. For opioid use disorder, in many ways, the treatment paradigm is turned on its head. Medication-assisted treatment is essential. If you don't give this, more people are going to die when their deaths were preventable. We do have the option of methadone. Here in Montana, we face a logistical constraint that there's not many opioid treatment programs. And the outpatient prescription really has to come from a pain service, not for use to treat opioid use disorder, at least not explicitly. For buprenorphine, this by far and away is the most available form of medication-assisted treatment. And remarkably, it is fairly safe. And I'll just highlight in one moment how respiratory depression plateaus at higher doses, making apnea very, very uncommon. And there's also the antagonist, naltrexone. It's an effective opioid blocker. The big burden that we face in considering this as a viable treatment option in our discussions with patients, we have to get them through detox. And for a lot of people, that's simply not possible. You still see significant benefit, of course, from the psychosocial interventions long-term once people are stable on MAT. And I think this is just another iteration of what we've already seen from my colleagues here yesterday and today. It's two charts comparing the impact of a full mu opioid agonist here on the left, fentanyl, versus buprenorphine. On the y-axis, you have ventilation in liters per minute. On x-axis, you have increasing doses. And you see with a full mu opioid agonist, highly potent fentanyl, ultimately you see apnea. the patient would die from respiratory depression without intervention. Whereas with buprenorphine, just as it is a partial mu-opioid receptor agonist, the impact on respiratory depression is ultimately limited, plateaus, and this makes it way safer. It's something we can do in a low barrier fashion and can provide ultimately in home-facing care. Thank you so much for your time. Want to open it up for questions. Here's my contact info. I welcome curbsides. For these 2 weeks, at least, I'm on 24/7 coverage of the EDs. So you can literally hit me up at any time if there's a question about an ED patient.
That was great. Thank you very much. Are there any questions out there? We're going to be putting lots of contact information out as we wrap things up by 2. But I hear a question.
Yeah, this is Ariana. I just wanted to ask about kratom. I actually treated a patient recently with buprenorphine, and I just wanted to see if you're routinely treating kratom withdrawal. In my experience, it looked exactly like heroin withdrawal, and the person had picked up kratom at 7-Eleven as a botanical to clear his mind and decrease his stress. And it was mixed with kava, I believe, and he was ultimately ended up buying it by the case. To a tune, I believe it was $1,000 at least weekly. So anyway, I just wanted to see your experience with that because that interests me, and I think that some of our folks may have some misinformation about kratom.
Yeah, it's super compelling case. Thank you. This is very, very pertinent. We're seeing more and more people getting exposed to kratom in some cases as an opioid alternative because it will act as a partial agonist at higher doses. Others are starting it for some pick-me-up. And sure enough, in Southeast Asia, indigenous use, going back 200-300 plus years, people would use it as a psychostimulant in some cases before any sort of arduous task. And at doses below 5 grams, the stimulant effect dominates. 5 grams and above, it acts way more like a narcotic sedative. And so what you can see in some cases, people in their early 20s, or if it's diverted, even teenagers get kratom. This is something that's available in most head shops here in Montana. And they'll start off using it, enjoy it as a stimulant. They build tolerance, the dose escalates. Next thing they know, they've gone from 1 gram a day to 10 grams, 20, 30, 40. For whatever reason, they lose access. While I was doing medical surgical ward consults at Billings Clinic, I treated at least 7 patients in kratom withdrawal. And it looks remarkably similar, if not identical, to opioid withdrawal. And they do very, very well with buprenorphine. And I think it's worth highlighting, and it would make sense pharmacologically. You can just fire away with bupe. You don't have to wait since the last dose of kratom. And that's because they're about equal insofar as the level of activation. There's probably not time now, but I have a slide that reveals it was a study I think done 2 years ago. They're seeing that overall the dose used of kratom tends to coincide with the dose of buprenorphine people stabilize on. By and large, people are stabilizing on lower doses of buprenorphine in comparison to folks with opioid use disorder. That said, once people are up at like 40 grams of kratom a day, they may likely need 16 milligrams of buprenorphine a day.
That was the dose that I gave. It was 16. And I thought he would need less. I was careful initially because I wasn't sure. So it's really interesting. I did that from my ED, and he actually did really well and said he felt normal, but that's interesting. My other question is, you're talking about those empath centers. Are these brick and mortar centers? I just wanted to get a little more information on that.
They are. And so the first one in the state, Eric Arzubi helped launch at Billings Clinic. And I see that there's a good question. I'll be right there. That was, I think, 3 years ago. So what it is an alternative to a psychiatric emergency department, really emphasizing we need to keep things as patient-centric as possible, minimize the iatrogenic effect of psychiatric hospitalization. Because what happens all too routinely if you go to a big medical center that has kind of the standard process of doing a safety eval on a patient coming in with suicidal ideation, and then potentially proceeding to admission. I can say firsthand through my training, which was just 5 years ago, basically, it's incredibly coercive. Once the patient is identified as a safety risk, they may be boarding in a psychiatric ED in a windowless room for up to 36 plus hours before they get admitted to psychiatry with very minimal contact with nursing, let alone with a psychiatric provider. So the empath unit has a psychiatrist, psychiatric nurse practitioner, someone who is expert in doing safety assessments and acute stabilization. They're on site, either virtually or in person, and they can, along with a social worker and the charge nurse, greet and assess patients as they arrive. And after the assessment is done, one of three things will happen. The patient will either be discharged with close follow-up, perhaps prescribed and indicated medication, receive kind of targeted psychotherapy, which may be purely supportive or could be motivational interviewing, depending. Pathway 1, pathway 2, the patient will be observed overnight in the empath unit. And that will allow everyone to get more data and also the patient to figure her or himself out. And so often when patients are intoxicated, that SI can at least partially resolve as people metabolize. And then, the third pathway, and this does on occasion happen, if somebody's overtly psychotic, it's primary psychosis, not meth-induced, or there is some profound psychopathology that essentially makes psychiatric admission unavoidable, you would, in that case, move to admit as immediately as possible. But in a low resource, when it comes to psychiatric bed state like Montana, this model has worked wonders. I saw it firsthand as medical director of the empath unit at Billings Clinic. Ariana, let's touch base after, because there's the Zeller model out of, I think it's Stanford, really explains this wonderfully. So to access our team for an ED consult formally, yes, it does require an agreement with the hospital. The reason being, it is a matter ultimately of credentialing. We have done pretty well with delegated credentialing to the point now that all of the 14 EDs currently we've contracted with, all but one have done delegated credentialing. What that basically means is the credentialing process of the hospital recognizes that we, as a practice, can privilege and credential our providers. And so kind of from signing of the contract to launch of service, we're looking now at about a 2 to 3 week turnaround. Our operations team is working overtime, and we're definitely giving Memora a run for their money to build out the infrastructure. The one really compelling thing about Memora and why we chose it in particular, it allows a click and launch feature. You may have seen with Zoom and other telehealth platforms, there's this concern of you have to download the app, maybe the app doesn't work, all sorts of things can go wrong. With Memora, they've done pretty well in making it so that all you need is access to the link, you click it, be it an iPhone, a tablet, an old computer on wheels in the ED. The encounter will launch and the psychiatrist will be sitting there in front of you. So we've been really pleased with that. One thing worth emphasizing, this is a service that, if anything, is going to be cost neutral to emergency departments. Reason being, we've done very well in facilitating the emergency departments being able to charge a facility fee for all these encounters. We do have a very, very nominal per assessment fee, but that tends to be significantly lower than the facility fee. And then the professional fees are what actually compensates our care. And we're able to manage that. So operations wise, it tends to be pretty turnkey for emergency departments.
Okay, any other questions?
Oh, I see.
Alan Meyer here in Butte. How you doing?
Hello.
Thanks for your talk. Very informative. And
Thank you.
So we have a big block of psychiatric services and facilities in Butte as I think probably most of the state does. And I think the empath idea is really interesting, but I think it's probably not physically feasible for most of the state to get people to a brick and mortar building. I'm guessing in Billings, maybe. Is there any way you could tie that into psychiatric admissions, let's say at our hospital, if we could talk to hospitalists and admitting these psych patients rather than hold them in the ER and then do your psychiatric care directly in the hospital here?
Most definitely. We'd love to. Let's follow up. That's currently what we're doing at a lot of the facilities we serve. We'll follow the patients out of the emergency department onto the floor, or if it's kind of a de novo psychiatric concern identified once they're admitted, we're happy to see the patient. So we have a working model. We'd be thrilled to serve these patients.
Yeah, and are you talking just the psych patients that have substance use disorder tied in with their psych? Are you talking about all comers for psych?
All comers, and to be clear, kind of really being a purist in the insistence that substance use disorders are within psychiatry. And this is a big deal for me as an addiction psychiatrist, because I've run into way too many psychiatrists who simply say, oh, we don't treat that. It's like, como que you don't treat that? Those are psychiatric diagnoses. So we will treat kind of really cut and dry opioid use disorder with nothing co-occurring. We find that if you do a thorough assessment, almost always there's something co-occurring. Now, could it be secondary to the substance use disorder? Perhaps, but we will treat it all. And that's really what we emphasize, in particular in our emergency coverage.
Yeah, I agree. I think all of us have seen where it's not one disorder or the other, it's usually both, seems like to us. So thank you. Maybe I'll follow up with you and see what you can do with it.
Excellent.
Okay, thank you so much. We are now at break time for lunch. And I put in the chat box the feasibility assessment document. My hope is that the bulk of you can download that and print that out for your work over lunchtime. Also, for those of you who received your boxes that I sent with materials, those will be contained within your packets. So let me tell you what is coming up next. I will share my screen. So what we're going to do today, of course, we're going to be having a working lunch today. You're going to be in your Zoom breakout group room during lunch with your groups, having one of our presenters join you at 12:15. So your task is to review the feasibility assessment and record what you guys identify as supports and challenges to implementing your own program, and then potential ways to address these challenges. We'll return from the breakout groups at 1 o'clock and have each group report out, which we're really excited about. And then we'll have closing announcements and we will wrap by 2. So I will make sure to broadcast these instructions when we get you broken out in your groups. And then let me just show you, this is what the feasibility statement the feasibility document looks like. And what we've done is we've listed out for you all of the different areas that you need to consider and look at as you're implementing your programs, okay? So any questions on that? So you go grab your lunch, come back into your groups. I will go ahead and do the group breakouts, and then one of our facilitators will join you at 12:15. Okay.
Tamara, can I add a quick thing to this?
Yes, and in connection to what I think you're going to say, I've got a document put together with everyone's contact information on it. So name, phone number, emails of your support team for this project, and I'll get that posted too. Go ahead, Greg.
Yeah, I just wanted to add, especially to the physicians and nurses that are on board and some that have come in and not through the grant at this point, but just learning more. I'm going to meet with Dr. Nathan Allen in just a few moments here to talk about more of how we can reach out and be of assistance. But I also want to, on that note, you'll see my contact information. I think you'll see Dr. Dan Knotz's contact information. I want to reach out to you to let you know, please contact me if you're interested in learning more, and especially if you're interested in learning about how you might be available to get some of this grant money to help you get this up and going. First, there's a feasibility studies and also looking at possibilities of getting this working in your ER. We know probably the best advertisement and the success of this program will be showing successes within Montana, and it will grow on its own, but need to find those places. So just wanted to let you know that that will be there, and please feel free to reach out if you want to learn more. I very well won't know the answer, but I know the people to go to. So thanks.
Okay, you guys, I'm assigning rooms. If any of you need to change, just let me know and I can get that taken care of. And we will see you at 12:15. Thanks.